area, Rajpur block of Madhya Pradesh, civil society organizations are building capacities of local self-government and women's groups so that need-based plans are prepared, they are proposed, agreed upon, budgeted, budget utilized, and community and the local self-government are tracking progress on their plans. The What Women Want campaign, a global campaign led by civil society organizations of the White Ribbon Alliance, is an example where more than 1 million women were asked their one need or demand for quality maternal health services. This has led to several policy actions, such as doubling the family planning budget of Malawi to address women's contraceptive needs. To sum up, I would say that civil society organizations are an essential part of planning and budgeting. They play a facilitative role in public-people partnership, and spaces need to be created for their participation and contribution. I wish you all the best. Thank you.
Greetings to all, and sorry I cannot be there with you in person. Thank you very especially to the government of the Republic of South Africa and to Align MNH for hosting this important conference, and also for the opportunity to share with you all a brief message. This meeting comes at a critical time. Amid the impacts of multiple global crises, the need to prioritize and finance maternal, newborn, and child health is now more urgent than ever. While countries have made gains in health outcomes over the past 2 decades overall, we're now losing that progress. What we're seeing are major backslides, especially at the cost of women and children. Every 2 minutes, a woman dies during pregnancy or childbirth. 1.9 million babies were stillborn in 2021. Behind these terrible numbers are millions of children and women who have been denied their basic rights to health. I know all of us here agree that this is simply unacceptable. And we also all know that what is at the root of this problem is chronic underinvestment in equitable, efficient, and quality primary health care, one of the most important vehicles for delivering maternal and newborn services. Primary healthcare systems that are not resourced to provide timely, safe, and high-quality care during pregnancy and the intrapartum period are not able to deliver good health outcomes. Institutional births alone are not enough. Quality must be assured within them. But with the collective commitment and collaboration from all of us, I know that we can flip the script. We can help countries build stronger, more integrated health systems that are resilient to a variety of shocks, including climate change and pandemics. Health systems with strong primary health care at their core, especially at the community level. In the World Bank, we're supporting countries around the world in their efforts to strengthen their health systems through a $34 billion global health portfolio that spans more than 100 countries and more than 240 projects. In addition, partnerships like the Global Financing Facility, the GFF, of whom I'm proudly the director, are supporting countries to further prioritize maternal, adolescents, and newborn health, and leverage more and better financing for this agenda, enabling the World Bank to mobilize an additional $1.7 billion allocated to women, adolescents, and children in its 36 low-income partner countries. Many of our projects focus on strengthening primary health care facilities with critical equipment, medicines, and supplies, and very special, with a trained health workforce to deliver maternal and newborn services safely and effectively. Our support focuses on innovative approaches, as well as in tools to better understand how to finance health systems in a sustainable way. I will close by saying this: maternal and newborn health will not only save lives, but also advance the rights and opportunities of women and children, who will power the productivity of future economies and the well-being of our communities and our society. The decisions and commitments we make today will have ripple effects on families, communities and economies for the years to come. The World Bank and the GFF are committed to rise up to the challenge and work with every one of you to create the impact we need for women, children, and newborns to survive and thrive everywhere. Thanks.
Good morning, everybody. You're awake, right? Hello, everybody. Welcome to the second full day of our conference. My name's Deborah Charles, and I'll be your moderator for today's plenaries. Yesterday, you heard all about the progress made so far in maternal newborn health and about a new coordinated effort aimed at aligning the community on joint 90, 90, 80, 80 targets that will help improve the health of mothers and babies. But while progress has been made, we know there is still a lot to be done, and we know the mortality rates have plateaued. There are roadblocks and challenges ahead, and that's what we're talking about today. And the morning plenary is about one of those challenges that can feel very daunting, but it's very important, and it's about money. More specifically, how to prioritize maternal newborn health, how to prioritize and finance maternal newborn health programs within primary health care. There's been a push to make sure that primary health care is prioritized as part of universal health coverage, but how do you make sure that the maternal and newborn programs don't get lost and make sure that the programs are fully funded and delivered effectively? And that's especially true now with the challenges in the global economy, the post-pandemic economy that we have. So we're looking to see how can we make the right investments to this vital part of healthcare. So that's what we'll be talking about today, and we have a great lineup of experts who will share their experiences and lessons learned and see if we can see a path forward. But first, we have a special guest speaker for us today coming virtually from Sierra Leone, and I'm very happy to introduce Dr. Austin Demby, the Minister of Health, and someone who's brought a lot of attention to the importance of maternal newborn health. Dr. Demby.
Well, good morning, moderator. Good morning from Freetown, Sierra Leone. I am honored and delighted to have been given this opportunity to speak today, to give the keynote address on the topic, how to prioritize and finance maternal newborn health programs in primary health care. Today, we are encouraged by the fact that the world is united in its commitment to ensuring that maternal deaths are prevented and perinatal deaths are avoided, as has been expressed in the SDG targets of reducing the maternal mortality and neonatal mortality rates to at least 70 per 100,000 and 12 per 1,000 respectively by 2030. To achieve this is no mean feat. It requires concerted and sustained efforts by all countries working together in solidarity. My country, Sierra Leone, has made steady progress in reducing the maternal mortality rates over the last decade, from 1,165 per 100,000 live births, one of the highest in the world then, in 2017, to an estimated 443 per 100,000 in the latest UN interagency estimates, making Sierra Leone one of the countries with the sharpest drop in maternal mortality, and for that, we're extremely proud. The national mortality and stillbirth rate, however, remains stubbornly high at 31 and 24 per 1,000 births, respectively. We're working to dramatically change that narrative. Sierra Leone has increased our domestic spending on health from 6% in 2016 to 11.7% by 2023. Despite this increase in domestic spending, This represents only 14.6% of the expenditure on health. 32.8% of expenditure on health comes from development agencies. 0.75% comes from insurance schemes, whilst 52.3% is out-of-pocket expenditure. There are efforts to expand on the government inputs, but this is limited by the GDP of the country. We anticipate that as the economy grows, the real value of our 11.7% will become even more impactful. The country is well advanced in instituting a national health insurance scheme, which will pool risk and resources and hopefully reduce the out-of-pocket expenditure. As we collectively work to achieve global maternal and newborn health goals, I would like to suggest that we pay particular attention to some of these thematic issues and priority areas. Policies and plans. As we develop new national health sector strategies, policies, and plans, as well as enhance existing plans around universal health coverage, we need to be deliberate in creating the enabling environment that ensures that maternal and newborn health programs are prioritized, costed, and central to all interventions. Quality of care. With some of the challenges we faced with COVID-19 over the past few years, we want to be sure to regain the momentum by continuous quality improvement approaches incorporated into maternal and newborn health service delivery. I believe that this will be greatly accelerating the progress we are already making. Effective referral systems. We need to strengthen our effective referral systems to ensure seamless linkages between the various healthcare levels so that conditions that cannot be managed at the primary healthcare level could get the required care in more advanced facilities, enhancing continuum of care and better health outcomes. The health workforce. We need to ensure that we have a fit-for-purpose health workforce to sustain and accelerate the progress we're making. The required health workforce needs to be available in the right numbers and with the right skills mix at different levels of the healthcare delivery system, from the medical specialists in the highest tertiary referral levels to the community healthcare workers in remote settings. Equity focus. We want to ensure that maternal and newborn health interventions are implemented with an equity focus so that no one is left behind. A primary healthcare approach to service delivery needs to be adopted and or strengthened. In Sierra Leone, for example, we have expanded access to healthcare activities through the establishment of 1,250 primary healthcare facilities to the extent that 80% of the population is within 5 kilometers of a primary healthcare facility, thus assuring easy access to the health system. What we need to focus on now is improving the quality of service delivered at these access points. Additionally, 8,700 community healthcare workers have been recruited, trained, and deployed to provide healthcare services in communities, especially the hardest to reach communities and households. Social behavior change communication is a very important aspect that needs to be addressed to ensure that populations have the required knowledge to make positive health decisions. Response and resilience should be underscored to ensure that the service delivery has the flexibility to adapt and remain functional even in the event of epidemics and pandemics or humanitarian crisis. Strengthening health systems will serve as a foundation for epidemic preparedness and response, which will also ensure provision of essential health services, including maternal and newborn health during epidemics or pandemics. We should invest heavily in effective data collection, monitoring, evaluation, accountability, and learning systems to ensure that the evidence generated is used to make informed public health decisions. Other key areas we need to invest in include supply chain, commodities, and equipment availability, as well as research and innovation. On the financing strategies, implementing these interventions will require huge financial investments and resource mobilization efforts. This could, however, be a major challenge, particularly in developing countries that usually have very limited fiscal space. Countries therefore need to develop the required compelling investment case and costly strategic plans that will be accepted by all in order to attract both domestic and development partners' funding. It is crucial that the Health Development Partners financing aligns with countries' strategic maternal and newborn health plans. The plans should be country-owned and country-led. However, such plans need to be co-created with development partners and the ministries of finance to ensure acceptance of both domestic and international investments. Domestic resource mobilization is critical for sustainable financing. It is therefore key that countries work with ministries of finance to have a budget line dedicated to these interventions. However, one of the challenges that many developing countries face is that most of the dedicated funding goes into addressing co-financing obligations, leaving very little fiscal space to address the health priorities earlier mentioned. Investment from health development partners and other bilateral partners will therefore need to be mobilized to address the funding gaps. A commitment to domestic resource mobilization needs to be made even by developing countries in order to address MNH priority areas. In Africa, for example, the African Union has encouraged all countries, all member states, to allocate at least 15% of their GDP to the health sector, their budget declaration. It is crucial to not only try to achieve their budget targets, but to ensure a good portion of the commitment funds address MNH services. There's also a need to shift from vertical investments in health programs to address the health issues using the life stages approach. We should ensure that the cross-cutting health systems issues are addressed. This will yield better results from investments made by vertical funding organizations such as the Global Fund and Gavi. We are encouraged that these organizations are also opening up to integrated approaches to healthcare financing. Health insurance systems are also an important mechanism to address maternal and newborn services. In Sierra Leone, there are plans to commence the National Health Insurance Scheme before the end of this year as part of the Universal Health Coverage Roadmap in my country. Another option will be performance or results-based financing systems, where payments can be made for maternal and newborn health outputs. This approach has also contributed to impressive results was implemented in the past in Sierra Leone. In conclusion, I want to be reminded that health is a human right that must be enjoyed irrespective of where we find ourselves. Let's continue to advocate for more investments in health with an equity focus using the primary healthcare platform to ensure that most vulnerable populations in the world are guaranteed quality and new health services. I wish to also appeal to my colleagues of health, colleague ministers of finance, to ensure that domestic funding for MNH services is prioritized. As I wish all of us well in our deliberations throughout the rest of the session, I want to appeal that we remain steadfast and focused in our work to improve on the health and well-being of populations across the world using the people-centered life stages approach. In Sierra Leone, we're working tirelessly towards zero preventable maternal infant deaths by 2030. Thank you very much.
Thank you very much if you're still there, Dr. Demby. And I think we have to thank the internet gods for working, that we were able to hear from Dr. Demby even though he couldn't be here in person. So next, I would like to call up our distinguished panelists to join me here on stage. And they're going to help us break down some of the mystery around health financing. Dr. Demby talked about it a little bit. How does it really work, and how can governments and countries do better financing maternal newborn health programs. Dr. Jessica, do you want to sit near me since I'm going to call on you first? All right, our first question goes to Dr. Jessica Nsungwa Saviti from Uganda's Ministry of Health. And we know that Dr. Dembi talked about this a bit, about the need, to get more money to maternal newborn health, but we know that even within ministries of finance, there are so many competing demands for limited resources, and as we saw a lot, I think, during the pandemic. How do you think about what budget is needed for maternal newborn health services, and how do you decide what to spend the budget that you do get?
Good morning, everybody, and thank you very much. I wanted to start by giving a small context about the country where I come from, Uganda. Uganda has one of the highest fertility rates in sub-Saharan Africa, and I think now it's ranking number 4 or 3 globally. So with a very high fertility rate, big population growth, very young population, and issues to do with adolescent pregnancy, high birth rates, and also young people contributing to mortality. Up to almost 28% of maternal deaths are due to births in young people. So considering the issue of how the returns we expect and where to invest, the issue of survival is the most important because we have an unfinished agenda. The benefits in survival in terms of having how many people survive because of the investment. In Uganda, for example, we have estimated that if we can invest in women and children, over a couple of about 5 years, we'll be able to save about 7,000 mothers. And that is a very important, significant input. But not only about survival, it's also about the health system costs. Many of these mothers, because of the delayed care seeking, coming in very dire conditions, and the cost in the investment in the care in the facilities market, leave alone the health system, other health system components like the human resource. So the benefits are quite tremendous. Moving away from the survival component, the issue of the human capital development. I think it has become increasingly acknowledged that human capital development is very important for the economic development of many countries. And it's also very clear that some of these human development endowments are transmitted across the generations. And it's important to know that if we can do human capital development very well, we could actually improve the productivity of our people, especially the role that women play in the human capital development. So not only are we going to save mothers in terms of numbers and save the cost of the health system, but we are also investing in the development of our future countries, in the productivity of our future countries, and making our economies more resilient to the shocks which we experience. I also want to talk about women and their role in production of health. We all know that in most of our poor countries, health is produced at home, and the role women play in the homes to make sure that diseases are prevented, that children are fed well, and the families are in a safe environment is very critical. And this indirectly saves on the costs, both for curative services, but also for health promotion services. I also want to touch about the role of women and the gender response and the contribution. I have listened to people talking about male involvement, and I know that in many setups, in many of our traditional setups, it's actually women who put off the men. So by investing in the women, we've seen that actually they've opened up the road for men, and male engagement has synergistically improved our care. Finally, I know this is a slightly new area for developing countries, the issue on climate change and the role of women in improving climate change. I think we have seen, especially in poor countries, that most of the work and the benefits and the success stories to do with protecting the environment and work around the environmental barriers and bottlenecks is actually through women. Most of the best practices we have in our part of the world has been through work through the women. So you can see that actually the benefits are actually marked, and they go beyond survival, but also they deal with productivity and our economy, and maybe safeguarding our future population through things like the climate change. I want to stop there.
Can I just zero in a little bit more on the actual budget? Like, how do you think about, how do you explain when you're looking for the budget money, how do you explain the importance of the maternal newborn health investments?
Yeah, in Uganda, we've been able to develop an investment case. We've been able to put a case based on looking at this thing from a different perspective. We have moved away from looking at interventions. I remember a couple of years when we used to discuss with finance, most of our discussions were based on projects for diseases, for diarrhea, for nutrition. But we've moved away from looking at that perspective, but also been able to situate ourselves in the way the country is thinking. We have an umbrella program which is looking at human capital development, and we are pushing 5 main shifts in our plan. The first shift, to be able to mobilize money for women and children, we have decided to go where deaths are highest. So we are using a targeted approach to push for progress. And we believe that because we are able to move to places where deaths are highest, the districts where deaths are highest, facilities where deaths are the highest, we are able to work on the equity aspect also. Because where women die most, you find that most of the other problems are also clustered in the same place. Beyond mortality, we are also looking at the burdened populations. We are targeting populations which are left behind. We know young people, newborn, refugees populations have been left behind as our main way of negotiating and prioritizing resources for maternal newborn child. So we have had to develop tools and data to identify these populations where we think the biggest burden is concentrated, and therefore been able to use little resources. We have also been able to redefine our essential package. I know the Lancet series defines so many evidence-based interventions, but we've stepped back and looked at our resources and our frontiers where we belong, and we have come up with a small minimum package which we are pushing for universal coverage. And these high-impact interventions, we think, will be able to deliver for us universal healthcare coverage. Many times people think that universal healthcare package is about doing everything everybody does in every country, but I think it's very important to domesticate this perspective and define what you can actually deliver. And that also has made it easier for us to discuss with Ministry of Finance that we're not going to solve all problems, but we want to do some things first. We also have a component for funding, which we're using to negotiate the multi-sector approach, because we know the human capital development is looking at converging different players, different sectors to improve learning. So our multi-sector approach as a key area for funding to push for women has been very instrumental, and we focus on things like adolescent health, nutrition, school health, and washing the health facility. And that way, we've been able to convince Ministry of Finance to put money here. And finally, accountability. Actually, one of our biggest budget is going into activities for accountability. Accountability not for resources only, but also for results. Having mutual accountability to the community, and also they themselves accounting to us. And through this process, we've been able to push for a scorecard, which we are using to negotiate with our leaders, but also to discuss at the grassroots level, to push for money to go in areas where we can visibly see performance. And we have annual review assemblies with everybody, but also we have had our partners align their commitments, make their commitments based on this one plan. So our plan currently costs about $25 per capita, and our health budget is $33 per capita. And you can see the demand is so high based on what we have in the country. So we have had to go outside and mobilize new resources. We are working with the private sector, but also we've been able to convince the government to get a loan from the World Bank and the GFF to push only for women issues. And through that process, we have also been able to convince the Ministry of Finance that actually we can work on performance, because many people believe that the health sector is a bottomless pit. So performance-based financing now is at the center stage of our work. And we've been very fortunate in the coming few years. The government now has decided to move away from input-based financing to performance-based financing, just by using our program for women and children as a tracer program. So in the coming few years, the health sector and the Ministry of Education will be funded through the performance-based financing. So we're able to give this proof of concept and work with the Ministry of Finance, and we're able to align ourselves with their thinking, but also the fact that we're able to cost our plan. We know how much our plan costs. We know how much resources we have. We also know we have been able to map the resource gap. So we've been able to discuss with them and become very flexible, and also be able to line up and sequence interventions which can be worked on.
Thank you. That was great. I appreciate it. But I realize I should probably move to another person on the panel to have some thoughts. Next panelist is Edwin Barasa, and he is a health economist and expert on health financing. So it sounds like it's not just about spending more money, it's about spending it properly and wisely. So how, in general, how can countries get more value from their investments in maternal newborn health, particularly if they're not getting a whole lot of money? So what's the best way to, not just quantity, but quality?
Yeah, thank you. Thank you very much for that question. I think when you think about, and Jessica has talked about this, it's really quite important for us to mobilize additional resources for the sector. But beyond that, we also have to think about, well, you have resources in the sector, how then do you use those resources? And the thing about financing and financing systems is that they do have an influence on health system goals. So, the way you structure your financing can affect whether you're able to achieve equity, whether you're able to achieve efficiency, and whether you're able to achieve quality. So if you structure your systems so that as you're spending your money, you're enhancing your health system goals. This is what health financing folks call strategic purchasing, right? And we need to do this because when we see the way countries spend the resources that are available, we see a lot of wastage, and we see a lot of sort of generation of incentives that compromise quality of care and so on. So how do you do that? There are several ways to do that. One is, and I think Jessica's talked about this a little bit, is to think about, at the first level is to think about how do you select the interventions that you actually finance. And what we see across countries is that you can either do that arbitrarily, so basically lobby for resources and fund whatever you want to fund, or you can think a bit more critically about the interventions that you're selecting to finance, so that you're getting interventions that give you the greatest bang for the for the money that you're investing. So using evidence-based priority setting processes to identify those interventions that are cost-effective, that give you value for money, is a very important strategy as countries think about structuring the maternal and newborn health programs. Now, at another level, so beyond selecting interventions, you also have to think about, well, where are you going to have your mothers and children access these interventions from? And again, financing has a very key role to play there, because you have to think about what health facilities are you going to actually pay to provide these services, and making sure that you're linking those decisions to criteria around quality, for instance, so that you're actually paying for quality. You're selecting health facilities using criteria that ensure that mothers and children are getting good quality care. Making sure that you're selecting those facilities that offer the greatest access, so in terms of geographical access, acceptability, and so on, begins to enhance quality of care, but also efficiency of the health system. And then lastly, you also have to think about, well, how do we actually pay for these services? So we've mobilized resources, but how do we actually pay for these services? And again, the way you structure your payment mechanism generates incentives that influence the behavior of healthcare providers. So you have to be, the system has to be conscious of that and has to structure payment mechanisms so that you are incentivizing the right behaviors and you're sort of mitigating bad behaviors. And I'll give an example. So in Kenya, we have several mechanisms for paying for maternal health services, and we have these two schemes that are managed by our national health insurance scheme. Now, one of the schemes is for all mothers. It's a free maternity scheme, and it pays hospitals about $50 for a delivery. So the payment mechanism is $50 for a delivery, regardless of whether it is a normal delivery or a cesarean section. Now, within the same national health insurance scheme, you have another scheme that pays the same health facilities $100 for a normal delivery and $300 for a cesarean section. So you have a facility that is dealing with, under one scheme, you have $100 for a normal delivery and $300 for another delivery, a cesarean section. And then other mothers are getting, their services paid for at a fixed rate, $50, whether it's a normal delivery or a cesarean section. And what we see is that when you look at the cesarean section rate, so what percentage of total deliveries are cesarean sections? Under the scheme that pays a flat rate across the two types of deliveries, it's about 8%. So 8% of those deliveries are cesarean sections. While the scheme that pays different rates, you have 36% of the deliveries being cesarean sections. So it tells you that the way you structure your payment is incentivizing these facilities to either over-provide, so to give unnecessary care, or under-provide. And either way you look at it, it compromises quality of care and it compromises efficiency. So really thinking about how you identify your interventions, where you're getting your interventions from, and how you pay for those services is quite important in financing, beyond just getting the money into the sector.
Yeah, that's a really good example too, because it is an increasing problem, right? With just you do it for the money, and
exactly.
Probably not the solution. Okay, thank you very much. I'm going to move to Dr. Tipawan Leabsutrakun. She's an epidemiologist who has consulted internationally on healthcare reform. So Thailand has been widely considered a success in its universal health coverage. How does Thailand ensure that maternal health care is covered, gets the right piece of the pie?
Yeah.
And sorry, go ahead.
Okay, thank you, Debbie. So, if we want to talk about the Thailand approach to universal health coverage related to the maternal and newborn intervention, I could not express well without the slide. So, I would like you to see the slide back to 1960, when Thailand has a maternal mortality ratio equal to 400. Thailand, we set the priority to maternal and newborn health, and we also implemented maternal and child health programs more than 6 decades. You can see that in 1960, we considering the importance of the skilled birth attendant, so we have the mixed availability of skilled birth attendants in community hospitals, followed by the strengthening the community hospital and primary healthcare setting. And also that we make accessibility for access to healthcare for the poor, and also enhancing quality of care. If you go to the slide, you can see that in 1997, Thailand has faced a global economic crisis that affected the population health, as 30% of the population were uninsured. At that time, the Thailand have established the universal coverage scheme in 2001, and also that implemented throughout Thailand in 2002. You can see that we have continuous expanding the benefit package to cover all population, including general population as well as maternal and newborn. And you can see that from 2018, we have the promotion prevention fee schedule that helping the people using health promotion and prevention, especially for maternal and newborn in the primary care setting. And at the present, Thailand, we have 3 main public health insurance that cover almost all the Thai populations. Nowadays, just only less than 1% of the people who were not registered in Thailand. From this slide, show you example about how we cover about maternal and newborn intervention. This slide just show you the selected maternal and newborn health intervention that even the National Health Security Office have managed by the for universal coverage scheme. However, for the health prevention and promotion, the disbursement, the universal coverage scheme also not only covered by NHSO. NHSO have responsible for all Thai population. So you see that from this slide, nowadays the fee schedule have cover for all mothers who come for antenatal care. And also for the newborn, they get the diagnosis and the prevention of the most common of diseases. And from this slide, you can see that what is changing. Changing is on the unsafe abortion and also contraception after termination of pregnancy. You may know that in the past, Thailand is not one of the countries is that the abortion is not legalized. And since you see that in fiscal year 2012, you can see that the list of prevention of unsafe abortion and contraception is the output is more than target estimated. It's because of we have the Penal Code 28 that 2021 that Article 301 and 305 that now the legalize the termination of pregnancy in the woman less than 12 weeks. And we also can do abortion without offense in some condition. That you can see that the output is 200, 300%. Because when we estimate the budget of the target, we have 2 years backward. That is why we not unexpected that we will have the penal code more open. Whenever we have some condition and we have the NH, the National Health Security Board, and also the Standard and Quality Control Board, and also the NHSO Executive, we consisted of the many Ministry of Public Health. We have the Permanent Secretary of many ministries, and we have representative of the health professional, and we have the representative for municipality, and at the community level, we have seen that what is the health problem of the Thailand, and we consider this in the budget estimating and health finance and mobilize human resource to cover the maternal and newborn health intervention and other health problems. That is give you example for Thailand.
Thank you very much. And now I'd like to turn, last but not least, Dr. Nirmala Ravishankar, a health financing specialist with experience working in Africa, Asia, Latin America. So we've been talking a lot about the national level budgets and discussing that, but if you could look at it more at a local, what are the dynamics more at a district level, and how can those dynamics impact how the financing for maternal health care is made?
Thanks so much, Debbie, for that excellent question, and indeed for inviting me to join this panel. I don't know if you remember yesterday when in the opening session, we heard there were 97 countries represented at this conference. There are perhaps a bit fewer today in the audience, but I'll wager most of those countries have a decentralized form of government. Some countries like India and Nigeria adopted a federal system right from the get-go. And then many, many more countries, low and middle income countries, decentralized decision-making power and resources to local governments in the course of the 1980s and 1990s. And it was driven a lot by a drive for democratization, to move services closer to the people, give people more accountability, as we were hearing from Smita in the opening video. So moving services closer to the people. And so if that structure forms the backdrop for most health reforms that we're undertaking, and it's critical for understanding financing for primary healthcare services, which is what we're talking about today. So most of the lower level facilities, health centers and dispensaries, and indeed community health workers, often fall under the purview of the local government. And those local governments, subnational governments, while they're not the ones mobilizing huge amounts of money, they're typically not raising much in taxes. They're not the ones writing investment cases, attracting money from donors. But when it comes to the allocation of funds, so they rely a lot on transfers from national governments, but they're the ones allocating resources to the facilities, to community health workers, et cetera. And how they make those decisions, what information they use, how robust are those systems, drives performance at the primary healthcare level. So that then brings me to the third point, that when we turn to look at how money is spent at that level, which is what Edwin was getting at, the budgeting processes at that level, we see a lot of weaknesses. And so, for example, you brought up, it's not just about how much money you have, but how much you spend. And budget execution rates at subnational levels, we've looked at about 8 countries in a report with WHO. Execution levels are 50 to 60%. So you're not going to have much luck speaking to Treasury asking for more money if you're not spending the money that you have, spending down that money and spending it well. The fourth point I think I want to bring up, it's not just about the local governments, but we actually need to go one step further to look at the facilities. How does the money flow to the facilities? How much autonomy do the facilities have? And indeed, these reforms to move more resources and autonomy and power to local governments have not typically led to more money and more autonomy for the facilities themselves. And actually, there's some tension there. The money, when it gets to the local level, tends to get stuck over there. And so there was work in Uganda almost a decade ago showing that money is not making it down to the facilities, which led Uganda to introduce PHC grants that go directly to facilities. There's been work done in Kenya by Edwin showing that when Kenya decentralized, it led to more money going down to the county level, but at the same time, it led to re-centralization within the county, away from the hospitals. So money was moving out of the hospitals into the county government. And why is that important? If you're running the facility and you've run out of soap, or you've run out of water, or an essential commodity, how quickly and how easily and with how much flexibility can you actually address those needs is driven a lot by the day-to-day financial and indeed operational autonomy that facilities have. So then the final thing, I just want to kind of pull all of this together to show how it works, how these dynamics affect a maternal health program. And I'll go back to the example Edwin brought up about a free maternity program in Kenya. It's a national scheme introduced by the government with a lot of commitment right from the top. It's universal entitlement, so any woman can walk into a public facility, get antenatal care, deliver her baby, postnatal care, and face no user charges. And the national government is paying for this. But when you go down to the county level, in several counties in Kenya, you see public facilities are not enrolling mothers in that program, and they're not claiming the money from NHIF. And when you start digging into why that might be, it's because they don't have an incentive. The money that NHIF pays, NHIF being the National Health Insurance Fund, that money is not staying with the facility, it's going to the county. And the county has a legitimate concern about accountability, and they need to track this money. The finance people want to focus on controls and so on and so forth. But it's a suboptimal situation at the end of the day, where money that the county could be getting from a national scheme, money that would come into that local health system, is being left on the table, so to speak, because the incentives at that local level are not aligned. So a lot of our work has been around bringing more visibility to those kinds of issues. Maybe just one final thought, right, or a quote. I want to, as I was thinking about this morning and yesterday's opening session, there's been a lot of discussion about policies, right? The importance of policies, and I think it was Professor Campbell who said, it's not just about having the policies, they need to be implemented. well, they need to be implemented well. And where is it really, where does the rubber meet the road? It's at that local level. And one of the sort of seminal pieces on project implementation or program implementation was by these two political scientists. And it has this amazing title, which is how great expectations from Washington, D.C. get dashed in Oakland, Oakland being a city in California, right? So how do these great federal programs, how do they actually translate to the local level? Involves all of us to look more closely at the implementation issues between subnational governments and indeed health facilities.
Thank you. And this sort of goes into this, and I guess, Edwin, I'd like to direct this at you, is how do you prove that things are successful? Is there like a system that you need to use to sort of, well, make sure, first of all, make sure that the money is spent, but how do you prove in order to get more funding and make sure the whole system's working? How do you prove that the investment is successful?
Yeah, I mean, so that's an interesting question. I guess it speaks to when do you know that your financing arrangements are appropriate, right? And we could go to some SDG indicators, for instance, a bit reductionist, but one of the things you think about is we have to make sure that people don't suffer from out-of-pocket payments. One, they're not suffering from out-of-pocket payments, and second, it's not pushing them into poverty. So those are the sort of minimal indicators that you look at. But really, those are not everyday indicators. They're not things you check every day. And so as a designer of a health financing system within a country, you really have to think about, let's have a system that protects people from out-of-pocket payments, but more importantly, and speaking to Nimala's comment about doing it well, you have to make sure that it is at scale, because a lot of countries try a lot of mechanisms, but they are small and fragmented. And so you have an insurance scheme here, you have another program here, you have another vertical scheme here, and so on. So they are not really at scale. And what that happens is that it starts to compromise many other things, including equity. So it has to be at scale, and it has to be equitable, both in terms of, so who are you actually providing coverage for? Are you providing coverage across the entire socioeconomic spectrum? Are you providing coverage across the key or relevant population groups? And here, again, to give an example for in maternal and neonatal health, and specifically for free maternity policies, what we see in terms of the evolution of free maternity policies in low and middle income countries is that they often start with thinking about the mother. So you have a grant policy, very well intentioned. Let's make sure that mothers don't have to pay when or rather women don't have to pay when they show up in a facility and deliver. And then it says nothing about the child that has just been born. And so over the next 4 weeks, and so if there's any complication, the family really doesn't have a safety net around that. And so what we see in these policies is that then there's a push and an evolution to include key interventions for neonatal health, so that you're not just covering the mother, but you're also covering the neonates and so on. So ensuring you're covering the right population, ensuring that your financing system is at scale, and then ensuring that you're structuring it to make sure that it is sustainable, for instance. Because again, a lot of, and I think Jessica talked about this, and the minister from Senegal as well, you have mobilization of resources, but a lot of that is coming from donors, and so you start having questions around, well, is this sustainable going forward? So sustainability becomes an issue, feasibility becomes an issue. How are you actually mobilizing those resources? Are you mobilizing those resources by using voluntary mechanisms, for instance, so begging people every month to pay? Or are you using more feasible alternatives like financing your system using taxes? So really thinking about promoting those desirable health system goals, but doing it at scale and doing it in a way that achieves equity is an indicator of a good financing system.
Right. So if I could ask each of you just to say in 30 seconds, what suggestions you would offer to everyone who's here listening at how to make sure the maternal newborn health programs get properly funded. And it can be at different levels, sort of according to what you all are experts in. I would love to hear, I know I'm just throwing this quickly at you, but just a quick, what would you suggest to these guys? Jessica.
Yeah, I think it's very clear that funding is not improving, especially after COVID. And many of our countries are aspiring to become middle high income countries. So more and more we're expected to take on our domestic resources. And that means we need to have smarter ways of financing. I think it's very important for the people who are working in maternal newborn health to have their data. We should know where and how much we want to invest, but also we should know how much money is available. We need to track the resources which are available, but also move into the issue of integration.
I'm going to cut you off there only because this is my rapid fire before we finish. What's your quick suggestion?
So I think get your case out there, your investment case there, know how much you need, and know where you're going to get your resources most, but also know your funding gap so that you're able to negotiate for this.
Great. Nirmala.
So I can just piggyback on that and say, once you've done all of that, you've gotten the investment case, you've gotten the money, tracking how it flows through the system, making sure it's, budgets are actually being executed at the local level. And here civil society has a role to play as well to hold local governments accountable. So those kinds of more downstream, perhaps less grandiose but important elements of expenditure, getting those right.
Edwin?
Yeah, invest in evidence-informed priority setting. So make sure you have systems that generate information around cost-effective interventions, and engage with finance folks, engage with people that develop benefit packages and so on to ensure that you articulate those key interventions in the maternal and newborn health space that have impact both in terms of health and in terms of cost-effectiveness.
Tipawan?
I would like to say that the primary healthcare setting under the support of the higher level is very important to improve maternal and newborn health. And also the health finance of the country needs to be well prepared to respond for any health challenges that we may face, because otherwise it will be disrupted for all maternal and newborn health of our country.
Yeah, I think as we said, I think they wrap it up much better than I could. So I'll leave it with their suggestions on what most needs to be done. Thank you so much to Tipawan, Edwin, Nirmala, and Jessica.
Thank you very much.
I think hopefully this helps. Sometimes the whole concept of financing can feel very daunting, terrifying, but very needed. So thank you for shedding some light on this. And I welcome you to either grab our speakers afterward if anyone has questions, or you can always message them through the Drifta app. So thank you very much, and we'll see you on the afternoon's plenary.
Thank you.